Thank you for the opportunity to speak here today. I'm speaking on behalf of my consortium members, that's the Dutch Post-COVID Academic Centers of Expertise. In Holland, we tend to call this disease post-COVID, as long COVID refers to pulmonary in Dutch, so therefore we decided to use a different term. I'm a clinical consultant in internal medicine and clinical pharmacology. We don't have any conflict of interest. We received some money by the government to create this care pathway. In the Netherlands, we are a somewhat small country. We have 18 million inhabitants, 7 academic centers, 113 hospitals, and 12,000 general practitioners, and almost all care is reimbursed by insurance companies. We do have many patients with post-COVID, about 1.5 million with mild symptoms, and about 100,000 patients with severe symptoms who could be housebound or bedbound. And as we spoke of yesterday and also today, this is a multi-system disorder with reported symptoms over 200. And in general, patients experience a lack in care in the Netherlands due to a fragmented care provided by various specialists. So there was an urgent need for adequate care. So the Patient Federation started a lobby which resulted in an assignment by the Dutch government in 2024 to develop a care pathway by providing 27 million euros to combine both care and provide real-world data to expand the care pathway to all lines of healthcare, so also provided by the general practitioner or smaller hospitals. With that assignment, we created the DPACE consortium, the Dutch Post-COVID Academic Centers of Expertise. We have 6 centers who provide adult care and 3 centers who provide care for children. It's a uniform data-driven approach to provide post-COVID care for having a structured diagnose and also provide off-label therapy. And the care pathway is dynamic in the sense that if new data emerges or evidence emerges, then we will also use it in the care in future updates. So this is what we did. We have a central registration by the GP. Because of the high number of patients, we had to do a random selection of patients who can be seen for providing care. We have a standardized intake, and then together with the patient, we decide what the dominant symptom is and provide off-label therapy for that. We asked the GP to make a selection of patients who could be registered, patients who have had complaints after the COVID-19 infection, at least for 1 year, and a significant loss of function with a Bell score of less than 75. And there should be no alternative diagnosis. So if a patient is expected to have also a depression, then we ask the GP to treat that first and then have a registration afterwards. And if possible, there should also be some paramedical care, like physiotherapy or occupational therapy, but unfortunately reimbursement stopped during the period of the expertise center, so that is not mandatory anymore. Currently we have about 15,000 patients on the waiting list, so we had to make a random selection who can be referred. And if a patient is accepted, we ask the GP to provide an extensive referral with also previous medical history. And on that information, we can do the triage, so patients can be referred to the nearest academic center. We have a standardized intake, more as that in detail in the poster by my colleague Daphne Schouten, poster number 14. but we do a medical history, some questionnaires, physical examination, NASA lean test, and extensive laboratory test. And together with the patient, we decide what the dominant symptom is. For the main pillars of symptoms, we decided post-exertional malaise, cognitive impairment, dysautonomia, and mast cell activation syndrome. As for these symptoms, there are off-label therapies available, proven somewhat effective in previous trials, smaller trials, not in long COVID, of course. During the visit, we also see whether the patient is adequately pacing and performs energy management. And if that's not the case, then we refer the patient to the occupational therapist. We start with non-pharmacological treatments. On the next slide, I'll show you what we advise, and also off-label therapy in a consecutive manner. So if option 1 doesn't result in any reduction of symptoms, we switch to option 2. And if option 1 has some effects but insufficient, then we add option 2. We evaluate every 4 weeks with domain-specific questionnaires. And in the end of the entire protocol, we aim to see the effect of this care pathway by comparing it to propensity-matched controls. And the controls we aim for at this moment is the patients who are on the waiting list who don't receive any treatments. In children, we have a somewhat more extensive way of evaluating off-label therapy, which is presented by my colleague Katinka Spekking. In children, we have the opportunity to perform NS1 trials. So in a crossover design, patient receives the off-label therapy or placebo in 4 periods of time. So these are the options we advise. Like my previous speaker, we have somewhat the same medication. So for PAM, low-dose naltrexone, for dysautonomia, fludrocortisone or ivabradine, for cognitive impairment, also LDN, and for MCAS-like symptoms, histamine blockers or mast cell stabilizers. On the right side, you see the Dutch Queen opening the COVID expertise center. So when we started, there was a lot of interest in this way of providing care for patients. We have money to have care at least till 2027. And at that time point, we hope to see at least 2,000 patients. And a few months later, have a final evaluation of the care pathway. At this time point, we had interim analysis. We have included 500 patients, predominantly women, with a mean age of 50 years old. Also, the dominant symptom is PAM, and many patients decide to try off-label therapy. During time, this, of course, can increase as this is performed in a consecutive manner. So in our DPACE cohort, we align triage phenotyping, and we capture real-world data in ways so we can provide a care pathway for other lines in healthcare, like the GP and other hospitals. We see that currently the interest for post-COVID is somewhat diminishing. So for the future, we really need to have everybody on board. So also future funding will be available. And hopefully this care can also be funded by healthcare insurance companies. And of course, if this shows to be an effective way of providing care, then we hope to expand it to other post-acute infection syndromes. I'd like to thank all the collaborators in this, so the various academic hospitals, but also patients' federations and the government. Without the collaboration of all these partners, this couldn't have been made possible. So thank you for your attention.